Thank you for that introduction, Dr. Staudinger. So before we get into the meat of this talk, I just want to talk about how I got into this work. Dr. Staudinger read about my history working in the ER, but I got interested in the opioid epidemic as a volunteer for the Harm Reduction Action Center in downtown Denver, where we provide harm reduction services from syringes and safe use supplies all the way to education and harm prevention and mitigation strategies to clients and an often stigmatized population. And so when I went back and got my master's at DU and had to do a capstone, I thought it would be a great opportunity to get into the academic trenches and sort of take on this passion of mine from a different lens. So here's this project. And what I want to do here in talking about the research I did here is paint a picture of what the burden of disease is and what we're doing about it and where we're going. So everyone's heard of the opioid epidemic, and the White House finally declared it a public health emergency in 2017. With that came more public funding and awareness. But even though we've had that, it's been 7 years and drug overdoses have continually been rising. So from 2019 to 2020 on the national level, we had drug overdose rates rise 31% to 92,531. It's pretty stark. When I did this research, I didn't have the data for the share of mortality due to opioids, but the year previous, it was 70%. So you can imagine that there's still a similar sharehold in this 2020 data. Now, zooming into Colorado, 54% increase in opioid overdose deaths from 2019 to 2020, 620 to 956 deaths. It's big numbers. Is a big reason that we're pursuing some new strategies to fix this. One reason that these overdose epidemic with opioids has been exacerbated is the emergence of fentanyl and other synthetics that are orders of magnitude more potent than maybe traditional forms like heroin that used to be an issue in past decades. Also, because there's cross-contamination with these synthetics in the general drug supply of people that are using drugs recreationally or, mainly just recreationally. And then when I say opioid overdose, what do I mean? I'm talking about respiratory depression incurred from the binding of the mu receptor. And that is the primary cause of opioid-related mortality. So enter naloxone, or Narcan, as it may be more commonly recognized as. But it's an opioid antagonist that binds with a higher affinity to the mu receptor than exogenous opioids. So it is the gold standard for emergency medical providers in the field to reverse an acute opioid overdose. And it halts respiratory depression and other adverse physiological effects of OD. And in addition to it reversing the negative effects, say you gave it to somebody that didn't have an opioid overdose, but was experiencing respiratory depression, you thought maybe they had an opioid on board and you gave it. Systematic review of a pretty sizable patient population of 36 patients showed that there were very minimal side effects to patients not experiencing an opioid overdose when they were actually given naloxone. So we have an effective pharmaceutical agent that works at reversing these negative side effects of opioids, and it is safe in the setting of non-overdose. So is it available? Well, in Colorado, at the time of this research, so back in 2022, there was standing orders in Colorado pharmacies for anybody to come in and say, I would like to get naloxone, and then walk out the door with it. You need to pay like your copay or whatever. But looking more nationally and broadly in the literature, I was sort of shocked to see that prescription of such a bona fide pharmaceutical agent that can reverse overdose is abysmally small. So 7.4% of ER visits for opioid overdose in this Chicago study that I'm referencing here, only 7.4 were sent home with a prescription for naloxone. So these were patients that had just had an overdose and they're not walking out the door with a prescription. And then to further compound that, those patients that are walking out of the door, 1 in 5 are actually filling it. So we're not getting many prescriptions for the patients most at need, and the ones that are getting it aren't filling it. So we need a new strategy. And enter the take-home naloxone intervention. And what this is to actually put the physical drug in patients' hands, along with education on how to use it at the point of care, at the bedside. So systematic review in the literature found that opioid overdose mortality was decreased in communities with take-home naloxone. I'll be abbreviating that as THN, and it's up here on the title, and you can see that going forward. So that's what I'm referring to. Compared to those without. And that met Bradford Hill criteria for causality. So it's a way to sort of give credence to a correlation argument. And it looks at like strength of association, temporality, consistency, dose response relationship, et cetera. With that in mind, this isn't quite like a pharmaceutical study where we've got like a number needed to treat to like eliminate hypertension, but I was able to drum up 2 studies that tried to find a number needed to treat to avoid 1 death, but it varied from 20 to 89 distributed naloxone kits. So I thought I'd put it in there because it's interesting, but I don't think it is going to carry much weight when we make our conclusions about what went down with this study. And then, so why do we think this is a good intervention? Well, in addition to actually reducing or counteracting the overdose, there has been some research that there are some fringe benefits with increased willingness to seek recovery services and to adopt other harm reduction practices. And it's been thought that this could be due to implicit messaging that is sent by a physician or someone in the healthcare space telling a patient, hey, it looks like you screen at risk for opioid overdose. We're handing you this medication that can be used to reverse an overdose if that were to happen, and that can save your life. And this is how you use it. And that message not only gives them the tools to reverse an overdose if, heaven forbid, that were to happen, it tells them your life is worth living. And we've, in the overdose and in the opioid epidemic and the addiction medicine community, that connection and community is like a huge talking point of how we're going to sort of come back from the detriments and the high mortality rates and addiction that we're seeing in this country. And then finally, you got to bring up the cost effectiveness, because that is how things get done in this country, is looking at where the money is. And so one study looked at for every dollar spent, there was $2,700 of savings. And so if it's going to save money, that's going to be a way to get legislation for more programs like this to be more widespread. Okay, where are we going to be distributing from? The emergency department. Why? Because emergency departments are seeing these patients that are at risk. One study had 5.5% of patients who presented for non-fatal opioid overdoses died within 1 year. And of those, 20% of them occurred within 1 month of their emergency department visit. So that means there's a significant number of patients that are in the ER and would be potentially screened at risk and given the drug at a vital time to it being useful for preventing overdose death. In October 2021, the American College of Emergency Physicians took a lot of this data that I've been talking to you now and put forth a resolution endorsing take-home naloxone through emergency departments as the best practice to treating patients for opioid overdose. And they also cited that systematic review concluded that they're uniquely positioned because emergency departments are commonly most prevalent source of medical care in both rural and urban communities. And then why we think this is a great opportunity instead of just going to the pharmacy is that sending out a prescription, as I mentioned earlier, it may not get filled. It's another step. They have to go through insurance. It also has a role of removing stigma involved. Through my volunteer experience working with patients that are struggling with substance use disorder, I've heard many stories of patients saying that they felt stigmatized by the medical community at large. And so to just put the onus on us in the medical system to hand this out to people instead of telling them they have to go and do it. That can make this the implementation of this as a public health intervention that much more effective. So enter the Colorado Naloxone Project. This was an initiative put forth by multiple organizations to implement these take-home naloxone programs throughout every emergency department in Colorado. And how do they do this? It's one thing to just sign up hospitals to say, yes, we would like to distribute, but implementation is so important. So they provided program development checklists, guides on how to use naloxone for both providers and for their patients. So they could give patient-facing literature as well as the facilitators like on the grounds, like nurses, doctors, APPs, tips on how to speak to their patients and guides to attaining reimbursement. Because again, we can't ignore the money factor in some of this stuff. And then I think this quote from Dr. Stater, who was my mentor completing this research, is really impactful. It's we need to decide that these patients with opioid use disorder and chronic pain are worth saving. And if they are, then we need to start exploring more aggressive strategies. Okay, so the research questions I attempted to address in my research were, what is the burden of disease attributable to fatal opioid overdoses? And does it differ between urban and rural communities in Colorado? Does the opportunity to distribute naloxone to individuals at risk of opioid overdose in the ED differ between urban and rural communities? And was there an appreciable difference in naloxone distribution between urban and rural communities in Colorado in 2021? And then finally, did this new novel public health intervention, Colorado Naloxone Project, how did it do in its first year? So to approach that, I just first want to define some stuff with my method. So this is a map of Colorado. These less defined lines are county lines, and the bigger ones are health statistics regions. So health statistics regions are a better way for like the Colorado Department of Public Health to report on health statistics when you may have like a less populous county, and so that I can appropriately report on, say, 7 over here, where there's not as many people and they don't have to go through masking protocols. And so I divided them into urban and rural health statistics regions based on definitions provided to me for hospital facilities by the Colorado Hospital Association. And then just a definition before we get into like the actual comparisons that I made. ICD-10 codes, they're billing codes that are applied to every visit. And we use those from the hospital claims data to define take-home naloxone eligible ED encounters. And so this is just a representation of what those sort of looked like. And so you can see adverse effects of opium or of fentanyl, initial encounter or subsequent encounter or uncomplicated. Like they're all just slightly modified, and they picked out 158 to use as the at-risk screeners that would trigger a patient to be eligible for take-home naloxone. So I took 3 data sets, or 4 data sets rather, and I put them together to make my comparisons, which I'll show in a flow chart. But just to define these data sets, one was a de-identified hospital claims data for THN eligible encounters from Colorado Hospital Association. Those were reported by facility for 2019, 2020, and 2021 calendar years. I had take-home naloxone kits distributed by the CNP, reported by facility monthly for 2021, because that was the year that it was implemented. And then I received overdose mortality data from opioids from the Colorado Department of Public Health, and those were reported by HSR for the calendar years of 2019, 2020, and 2021. And then I got mid-year population estimates from the U.S. Census Bureau, and I got that by county and was able to organize that into HSRs. So I had a larger flow chart that I could have like walked you through all of my methods, but that's sort of boring. So I just want to talk a little bit about what I did. Is I needed to assess my research questions, I needed to take the take-home naloxone kits and normalize them by overdose deaths or THN emergency department encounters, or population. And that's because when I'm looking at, say, the really populous HSR that had Denver in it versus a more rural one, you need to have some normalization factor. And so I took these normalizations, and when I was performing my tests, I had to implement some exclusion protocols because the data was a little funky based on what was provided, and it didn't seem to mesh with the masking protocol. And so in discussions with my precept or my mentor, we decided to remove a couple for some of the tests. But we performed a chi-square analysis of the take-home naloxone kits given out for THN eligible ED encounters between the rural and urban groups, and then a couple ANOVAs and 2 sample t-tests, which I'm going to explain to you. But first, let's look at the aggregate descriptive statistics for Colorado on whole. So I want to clue you in here. Total opioid overdoses in urban and rural and statewide communities. You can see a clear trend of increasing opioid mortality. These numbers have doubled almost in 3 years, and that's really concerning. And so I think that highlights the burden. I next want to draw your attention to fatal opioid overdoses per THN eligible encounters. So that's like the population at risk. Like this is THN eligible encounters is how many times somebody's coming to a ED and could possibly be receiving naloxone. We're having more overdoses for that number down here over the years in both rural and urban communities. Bring it down to overdose mortality per 100,000. That is also increasing. So across all communities, urban and rural. And then THN kits. So this is actually the distribution of naloxone into patients' hands that are at risk. Those normalized by fatal opioid overdoses or the opportunity to distribute or to per capita basis are higher in urban versus rural communities. So just on its face as a whole, the urban facilities in 2021 were able to distribute a little bit more efficiently, but I've got some caveats to that, which we'll talk about later. So for my first statistical analysis, was distribution of naloxone to THN eligible ED encounters more likely in urban or rural facilities? By chi-square analysis, I took the number of urban THN eligible ED encounters statewide, and I broke it down into the ones that got naloxone, and it was 14% of the eligible encounters received naloxone, whereas in a rural community, that's 3.5%. And so the chi-square analysis returned a statistically significant value. And just by comparing these, you could see that patients that were at risk for opioid overdose were 4 times more likely to receive the new and novel public health intervention at an urban facility than if they were to show up to a rural one. Okay, now our THN eligible ED encounters per 100 or 10,000 people. There was no significant difference in the opportunity to distribute naloxone based on the number of eligible ED encounters per capita. And so when I say there's no significant difference, we usually think that's a bad thing. You can't report on that, but I think that shows that both urban and rural have an equal opportunity to be distributing naloxone. And on to my next is fatal opioid overdoses per 100 THN eligible ED encounters. As you can see here, we have a much higher mean in the rural versus the urban cohorts. And so what's that saying is that the rate of fatal opioid overdoses in rural communities is outpacing that of urban communities in relation to the number of total ED visits where patients screen at risk for opioid overdose. So this sort of highlights the burden of opioid overdose mortality in rural communities and demonstrates the need for this type of intervention. And specifically, if we were to go back 2 slides for the rural communities programs to perform better than they currently did in this study. And then fatal opioid overdoses per capita, 100,000 people. I was able to return a significant value for increasing opioid overdoses per capita over the 3-year period. And this sort of justifies any expense, well, maybe not any, but it justifies further expenditure than is currently being given, and to support these new types of programs that would benefit reducing opioid mortality. And the lack of location effect, it just found it based on year, showed that fatal opioid overdoses are similarly prevalent per capita basis in both rural and urban communities. And I just put this in for posterity's sake. I wanted to see if there was any difference in the distribution of naloxone kits normalized per fatal opioid overdose or per encounter or per capita between rural and urban communities. And as you can see by the error bars, this data doesn't mean anything. So we tried, didn't do anything, and I think, has more to do with the way that the data was collected. And in a 1-year master's program, we were only able to use mostly publicly sourced data and stuff that had already been packaged. And the variability could have been due to the presence of certain hospitals distributing 0 kits, and then that leading to the presence of 0 values. And when you try to normalize with that, that just mucks up the data. Another thing had to do with a rolling admission, which I'll talk about in the limitations. So hospital claims data, for one, has a lot of limitations. While it's great, the hospitals are creating this data for themselves, for billing, for their own, research purposes. And so it's a great source to go through and look back at things retrospectively. But in this study, our main limitations arose from, we were given total ED encounters and not unique visits. So when I'm talking about the number of THN eligible ED encounters, that's not the number of patients that were at risk. So it's not describing the population at risk per se, but more the opportunity to help that population. So I think that is still of merit, but it's an important distinction. Along those same lines, it does report visits in a facility and not if the individual is from there. So I could be from Denver and reporting to a facility in a rural area of Colorado, and I get counted in the rural area. And so it doesn't say that rural community, like rural citizens, are necessarily at a higher risk compared to urban, but it is saying that a facility is having this burden, which I think is also an important distinction. And a value to be presenting on. Reliance on our ICD-10 codes to define a THN eligible encounter may skew the data a little bit, because a patient it assumes that a patient is recognized as being at risk for opioid overdose in the moment, and not and actually being given this by the healthcare providers, because we're just looking back at ICD-10 and saying, okay, well, they should have been given this, but there's a potential disconnect. And that's an area that could be improved upon by EMR implementation of pinged messages once you add in the ICD-10 code and try to discharge a patient from the ER. And it also doesn't account for refusal of naloxone. So potentially you have somebody coming in and refusing, and that looks like then the hospital is not doing a good job at distributing, but maybe the patient already has naloxone. And then I referenced the rolling enrollment and how that probably skewed the data too. And so with any novel intervention or program, you're going to have like the early adopters and the late adopters, right? And so it just so happens that there were already 26 urban take-home naloxone programs as opposed to 5 rural ones before this project started. So at the get-go, there was probably more, or there were more urban versus rural. And then as that year went on and you sign on more people, there's a ramp up period. Like maybe we fill out the paperwork, but then we have to educate our staff. And by the way that the data was collected, you could tell that some programs were starting in June, where some didn't get going until November. And when we're looking at calendar year data, those programs that based on the masking program protocol, I wasn't able to sort of parse out in a better way. So that's an opportunity for future studies to maybe dig into a bit more. So my recommendations for future studies would be to eliminate repeat visits to quantify the size of that risk population, to track patient demographics to better characterize population at risk. And so if you were to go through a more formal IRB study and get a more robust, like linked data pull, you could find out if certain age demographics or certain racial demographics or comorbidities were being delivered this intervention or coming in and screening at risk for opioid overdose. And that can help tailor further public health interventions to treat the population at risk. As I mentioned, I think repeating the study with a full year of data would remove that rolling admissions effect. And then, gold standard, let's find a prospective cohort study. That might be a little harder to do. But I think looking back at what was done this first year and subsequent years for the Colorado Naloxone project would be a boon to them in demonstrating how successful they were when they want to roll this out to other communities. So just to revisit our research questions real quick. Did the burden of disease differ between urban and rural communities in Colorado? Opioid mortality is an increasing problem statewide, worse in rural communities relative to the number of THN eligible ED encounters. So it did differ. And the caveat to that is there were more total opioid overdoses in the urban HSRs, but that makes sense because it's a more populous area is going to have a higher actual gross mortality rate compared to a normalized. Does the opportunity to distribute naloxone to individuals at risk of opioid overdose in the ED differ between urban and rural communities? It does not. The two-factor ANOVA of THN eligible ED encounters per capita showed no statistically significant difference in the means of urban and rural communities to distribute naloxone to individuals through emergency department, independent of location. There was some slight differences, like the mean here of 35.84 THN eligible encounters in the urban versus 27.6 in the rural when normalized per capita existed, but it didn't throw off the statistical analyses. And then was there an appreciable difference in naloxone distribution between urban and rural? Yes, 4 times more likely as a patient in need and at risk in presenting to an urban facility to receive than their rural counterparts. And then how did the Colorado Naloxone Project do in its first year in implementing THNPs in EDs across the state? I would say super well. They enrolled 75 new emergency departments, which is a 242% increase. Through those programs, those in the EDR, 2,500 THN kits distributed. And based on that number needed to treat, which I said maybe we don't give too much credence to, potentially 28 to 127 opioid overdose deaths were avoided. And this is just a map showing the sparse number of THN programs throughout the state beforehand and how much more widespread they were afterwards. Thank you, guys.